Greetings and welcome to the very first Town Hall of 2024, our 42nd overall. It's great as always to see each of you here, and I want to thank as always the members of our Society for Leading Medicine and I want to thank our chairs Waverly and Adam Peaks and Kristen and John Berger for ably leading that this past year and now into 2024 as well. We've got a very interesting presentation today and discussion today around two topics that I know will be very interesting for everybody here. One of those is around sports concussions, and the other is around a burgeoning and wonderful new partnership with Rice University, the Center for Human Performance. One of several great partnerships we have underway with Rice University, and one of the wonderful things about our being an independent academic medical center is we can work with different partners around different strengths and mutually beneficial programs. Today I'm joined by Dr. Pat McCulloch, who's co-director of that center, and Dr. Ken Padel, who's the director of the Houston Methodist Concussion Center. As always, if you have questions, please text them to 37607. You text the word DeBakey to 37607. We also have a live stream chat, and that live stream chat has Dr. Brad Lambert, who's the lab manager of the Center for Human Performance there to answer questions around that center, and Deidre Duke, an athletic trainer and liaison in our concussion center, who can answer many of your ongoing questions there as well. So first I'm going to start with Dr. Padel. We've gotten many questions in advance. So many of us have children playing high school sports and sometimes college sports and other things, and are very concerned about our kids getting concussions in sports, particularly in certain sports. So we'd love to hear the latest from you around concussion.
Thank you, Dr. Boom. Morning, everyone. Thanks for joining us at our Houston Methodist Town Hall meeting. And today, obviously, we're going to talk about concussions in sports. I always like to start off with what a concussion is, just to give a real basic definition. Simplest way to think about it is a disruption of brain function induced by trauma to the head and then thus to the brain. This tends to cause a chemical disruption in brain functioning that takes maybe about 7 to 10 days to fully recover. And during that recovery period is when we're seeing a lot of the symptoms. Center for Disease Control estimates about 3.8, maybe 4 million head injuries occur in the United States each year. About 75% of them are concussions or mild traumatic brain injury. One of the important things to remember is loss of consciousness is not a common effect of concussion. Only about 10% of individuals will sustain a concussion, so we never really use that to determine if someone had a concussion. Besides affecting the brain, concussion is what I refer to as a multi-system injury. It affects a lot of different parts of the body. It can affect your neck, your eye movements, your balance system, your mood, energy level, all of those things. And that becomes very important when we decide or how we treat concussions. We need to apply this multi-system clinical assessment where we pretty much look at 7 different aspects of the body. When we do this, we can develop very individualized treatment plans to help the patient to recover a little bit faster. Concussions are very treatable, and the sooner we evaluate them and look at them in detail, the quicker we can come up with a treatment plan. If we look at concussion rates, obviously they vary by sports. Collision sports or contact sports versus non-contact sports are going to differ greatly. And also age tends to make a big difference in the rate of concussion. So for example, if you look at youth football, 14 and under, about 5% of those individuals might get a concussion during a season. If we go to the high school level, about 8 or 10% of all injuries at the high school level are involved in concussions. In this graph, what you can see here is what we looked at different sports. You have football on the left up to baseball, and you can see that it's going to vary by sport. And this is for male high school athletes. And what's also very interesting in this slide is if you look at the dark blue, that's competition. The lighter blue is practice. And you can see a big difference, usually 5 or 7-fold difference in the rate of concussions. And what we've done over the last several years is we've actually reduced concussion rates in practice a lot. And that's something we've worked on. We have a little bit more work to do when it comes to competition, but you can see here that the contact sports such as football are going to have a higher rate. If we look at females, it's going to differ a little bit, and soccer tends to be one of the higher concussion rate sports for female athletes. And again, the same pattern here where we have more in competition than you do in practice. Here's an interesting slide that I always like to point out. And what we have here in the dark blue are females, the lighter blue are males. Females will have a higher rate of concussions than males in comparable sports, so soccer, basketball, baseball, lacrosse, things like that. And that's something that we really try to pay attention to when we talk about prevention and education in that. And why we all do this is we really want to prevent the risk of multiple concussions, particularly in sports. And there's a lot of reasons for that. And one of them is that what we've shown over the years in the research is that if you get a concussion playing a sport and you continue to play in that competition, you're likely 2 to 4 times more likely to have a longer recovery with more symptoms. So actually the quickest way to recover from a concussion is to not tough it out, but to kind of pull yourself out, or to have an athletic trainer or coach pull you because of the concussion. What's even more important is that what we do know is that sustaining that second concussion before that previous concussion is healed is an increased risk for a more severe brain injury. Anywhere from lasting a little bit longer, having more symptoms, to something that's very, very uncommon but can happen is where you have a lot of swelling inside of the brain. So we are very, very careful about this. And one of the things that has happened is all 50 states have concussion laws, particularly around sports. And they're designed to get players out and to make sure they've fully recovered before we return them to play. If your child has had a concussion, what to do? And for the first several hours, we do want to monitor the individual, 3, maybe 4 hours. And what we're looking for are any changes in symptoms. And there are these red flags or danger signs that we do want to pay attention to. If there was documented loss of consciousness, if they vomited 2 or more times, if they have any numbness, weakness, or tingling in the neck or arms or shoulders, these are all kind of red signs that you should take your child or the patient to an emergency room to be evaluated, just to make sure everything's okay. After a couple of hours, you can start treating the headache. Tylenol only, never give aspirin, as it's a blood thinner. And we also recommend no ibuprofen, naproxen, that's Motrin or Aleve, for the first 48 hours. After a couple of hours, they can go to sleep, and we do recommend sleep. That's the way the brain tends to heal itself. No need to wake them up in the middle of the night anymore. And please keep the patient hydrated. Appetite could be down, but it's very, very helpful to keep them hydrated. And we do recommend a consultation with either your primary care doctor, pediatrician, or a concussion specialist so they can decide what the appropriate treatment plan will be. Common question I get, particularly around football and contact sports, are advances in protecting the individual from concussions. A lot of different devices out there, little ways of trying to prevent it. What's been common in the last year is Q collar, where they wear that around their neck, and it puts a little bit of pressure on the jugular vein. What that basically does is kind of causes a little backflow of blood flow in the brain, and it kind of cushions the brain a little bit. There is some data that shows that it does prevent, the term they use is brain slosh. It prevents the brain from moving back and forth in the skull. And there's evidence to show that that decreases the effects of what we call subconcussive hits, the little hits that don't cause concussions. Unfortunately, what we don't have is any data that this type of device actually reduces concussion rate, and we're still waiting to see that. If you followed the NFL, you might be aware that over the last 2 seasons, the NFL has mandated the use of the Guardian cap. It's a soft shell padded exterior that fits over the helmet. It's used in preseason and practice, and it's designed to reduce the amount of energy that goes into the helmet. We're only in the 2nd year, so we're waiting for a lot of this data to come out. There is some preliminary data that says it might be reducing the rate of concussions. However, this has never been used or studied in younger athletes. The helmet does create mass, and with younger kids, you might have more bobble or more wobble in the head. So we do need to make sure that it's going to be safe for our children to wear before we start implementing it for our younger athletes. Helmet manufacturers are always tweaking their helmets to try to make them safer and more protective for the head. Foam fitting inserts that really nestle the head and add some cushion to it. Changes in the materials, flexible patterns that are designed to absorb or redirect the energy from two helmets hitting, improvement in peripheral vision in the helmets, as well as better sensors. If you are buying a helmet for yourself or for your child, I do recommend the Virginia Tech Helmet Ratings. It's a completely independent rating system, and they rate all types of helmets, bike helmets, football, ice hockey, lacrosse, and very, very good ratings to look at how well they protect the head from the energy from a hit. And I would recommend using that. And what you'll notice is that a lot of times the most expensive helmet isn't always the most protective helmet. One of the things we're doing at Houston Methodist is we're really trying to work on the prevention to try to minimize the getting concussions and the effects from it. One of the things we are doing is education. We do a lot of educating the community about educations and treatment and recovery and return to learn and return to sport. Proper technique is critical. We did a study earlier with sports medicine that's showing that proper technique can reduce neck injuries by up to 40%. Neck strengthening tends to fly under the radar, and I really like to push neck strengthening for our female athletes. Literature is very clear that stronger necks can reduce concussions and whiplashes in our athletes. With our younger women, their heads develop faster, so they tend to have larger heads relative to their necks. So again, it tends to be more wobble, and we try to reduce that by building up their neck and their upper backs. One of the things that I've been trying to emphasize a little bit is right-sizing the sport to the age and physical maturity of the player. We do this in soccer with the size of the soccer ball, as well as the age of the player, and I think we can start looking at other contact sports to start doing that. When, for example, when would be the best age to start tackle football? Okay. What you'll see is in all the states, they do have specific protocols that student athletes have to follow in order to return from a concussion. The student athlete needs to be cognitively intact, and they have this 5 to 6 day protocol of increasing physical activity to get them back to their sport. And this has been updated and tweaked, so it is following some of the more recent science. So we do this. And Houston Methodist does advise about 47 or almost 50 public school systems throughout the state of Texas in developing their return to sport protocols. And just before just to wrap up, a little bit about the Houston Methodist Concussion Center. We are a comprehensive system-wide program. We have over 20 healthcare providers consisting of 6 different medical specialties, and we have a little bit over 15 locations throughout the area that we see patients. Many of our sites offer same-day, next-day appointments, and we do treat any type of concussions. It doesn't have to be sport-related. It can be falls, accidents, motor vehicle accidents, things like that. And last year alone, we saw about 1,500 concussion visits throughout the Houston Methodist system. We do have a pretty good reach across the state. A lot of this, I do like to give a shout out to the Houston Texans. They are big supporters of the Concussion Center, and they allow us to go out into the community. One of the things we've done is with Deidre Duke and I have developed an online 2-hour training program. State of Texas mandates this for individuals involved in sports in the public school systems. Last year alone, we educated and trained over 6,300 individuals. We do have a large teleconcussion program. It's been about 6 years now, and this allows me to treat and to evaluate individuals in rural areas that don't necessarily have access to concussion care. Everywhere from the Louisiana border all the way back to Uvalde is where we're trying to take care of these individuals. We've been doing a lot of research. We had a publication a couple years ago. We were the first in the country to show changes in the gut microbiome following a concussion or participating in year collegiate football. We are in the middle of developing a smartphone app for real-time assessment and treatment planning. I think this is the way we can really start to tweak how we treat a lot of our concussions. And lastly is our community outreach. We do a lot of education in the community. to schools and other healthcare organizations, and last year alone we did about 40 presentations. So with that, I will wrap things up. Thank you for your time, and I look forward to answering your questions in a little while.
Well, thank you very much, Dr. Padel. We'll come back and do some dialogue in a little bit. I'm going to turn it over to Dr. McCullough, who's going to talk to us about the center we talked about.
Great, thank you. My name is Patrick McCullough, and I'm an orthopedic surgeon. I practice sports medicine and shoulder surgery. I want to thank Dr. Boom for inviting me to be part of this conversation. And I'm going to talk about an exciting new venture for us, which is called the Houston Methodist Rice University Center for Human Performance. And this is a new collaborative center, which is the latest and greatest iteration of prior labs that we've had within our department. So you may have heard of things like a gait lab or biomechanics lab. Well, we've incorporated all of those into a much larger, more complete lab. And this is part of a larger vision of collaboration between Houston Methodist and Rice University. Those are two great institutions that are involved in research and education, and since we sit right across the street from each other, it makes perfect sense that we become more aligned. And this will offer expanded capabilities to fulfill our department and hospital research goals. So human performance, to me, I always think of this in terms of how is this going to help our patients, right? And so I think in terms of injury prevention. So getting them before they actually get injured. But if they do, then optimizing their surgical outcomes and looking at ways to improve their rehabilitation, either from injury or surgery, and maximizing their performance when they return to play. And along with that, our charge would be to help develop new devices and testing protocols that help us with all of those things above. So this center is a 6,000 square foot space, and it sits in the Tudor Fieldhouse directly across from Houston Methodist. And this is the first time that Rice has ever allowed any other institution to build on their campus. So groundbreaking in more ways than one. The construction and planning happened during COVID, and we actually held our grand opening event in October of last year. And we have all of the different departments within medicine here at Houston Methodist, but it allows us to then collaborate with other departments like engineering, kinesiology, computer science, and athletics. So if you look at the two pictures on the right, we have in the bottom picture, that's Ed Jones, who runs our research institute and was really instrumental in helping to get this center built. And on the far right of that picture is Reggie DeRoches, who's the new president of Rice University, and I really think a truly transformative leader for Rice, and I'm very happy to work with him. In the top right, you see one of our Rice athletes, and that's Luke McCaffrey. So his father was a famous football player. His brother is a famous football player in the NFL, Christian McCaffrey, who will still be playing this weekend in the NFL NFC Championship game. So as good as Luke was, and he'll be off to the NFL next year, he still wasn't good enough for Rice to beat Texas. So this is our research team, and there are some people that I wanted to point out. So Brad Lambert is our PhD exercise physiologist, and he serves as our lab manager. He, along with Will May, who is our operations manager, were really instrumental in designing and purpose-building this space to get it exactly the way we need to fulfill our mission. And Dr. Lambert is on the chat line, who will be answering questions as this goes on. I serve as the co-director of the lab, both because of my responsibilities within the Department of Orthopedics and the fact that I'm the head team physician for Rice University, which sort of put me in the catbird seat. We were fortunate to hire Jordan Ankerson, who is a research PhD, and she serves as our research engineer and does a lot of our computer reconstructions and 3D modeling. And while this is open to anyone in the hospital, a lot of people in orthopedics have been working in the lab, and I've listed some of my partners who have been performing research in the lab to date. Now, what does this space look like? Well, this entire space allows us to look at what we call motion capture and to look at how muscles fire. So in this space, there's a truss system that's on the ceiling and on the walls, and on this truss system there are 24 very high-tech cameras that can then capture even the most minute movements So whether that's someone performing a ballet maneuver, or playing violin, or running, jumping, or throwing baseballs, we can capture all of that in the center. And in the floor is embedded with force plates, which then allow us to look at reaction time and their ability to cut or push off with different legs. And then if we add to that other devices like this really cool Bluetooth EMG sensor. So that allows the athletes and patients to be free to move, but yet we can measure when their muscles fire, the sequence at which they fire, and the strength. And what does this help us to do? Well, if you've ever seen how they make video games, it's very similar to this. So we can mark up patients or players with these reflective markers, and then we can capture all of these movements and build a 3D model that allows us to study this. And so this could be, for example, evaluating a new design for total knee replacement, or a new technique, where we want to see, does it perform better with stair climbing or with jumping? It could also be analysis of performance. So if we look at pitchers, for example, who maybe got injured, we may want to have their mechanics locked into the computer, so afterwards we can go back and see, are they truly ready to return? We also have specialized instruments to look at strength and balance. And if you look at the top right, that's a biodex balance testing, and that's actually really critical for returning after injury, and in fact plays a role in concussion. So we'll often be evaluating when that balance returns to normal as a marker for when they've recovered sufficiently from concussion. Many of you may have heard of a DEXA scan looking for osteoporosis, and DEXA scans can look at bone density, but we can actually look at it for region specific. So we can look, for example, after a fracture or after an injury, just around the knee to say, is that bone density where it needs to be? Where we more often use it is actually looking for body composition. So we can look at lean muscle mass in a specific limb or in their lower body, for example. And if we do an intervention, whether it's a strength training intervention or maybe a dietary intervention, we can actually measure very accurately whether they were able to gain increased lean muscle mass. We also can do all the metabolic testing, and we can take tissue samples. So if you've ever seen the futuristic Ivan Drago training to fight Rocky, well, it's not futuristic anymore. We have these, and these are standard for what we use to evaluate the expired gases when someone is exercising. And we can do what's called VO2 max testing, and many of you may know from your Apple Watch or your Fitbit that it'll often give you an estimate of your VO2 max. But a lot of these wearable technologies are not particularly accurate, and we can validate new devices that come online in the lab. Next up, I'm going to show you a short video that we prepared inside the lab where you can see some of these things in action.
Houston Methodist is committed to leading medicine and pushing the boundaries of what's possible across a range of disciplines. Building on a history of collaboration with Rice University, the two institutes have joined forces to create a premier research center that will allow scientists to advance translational research, education, and clinical care initiatives in the field of human performance. Here, Houston Methodist physicians and academic researchers and Rice University faculty and students will work side by side with student athletes, trainers, coaches, and kinesiologists to advance joint research in exercise physiology, injury prevention, and rehabilitation. The center's high-impact findings can efficiently translate from concept to application in the clinic or practice field, enhancing recovery from a joint replacement or augmenting preseason baseball training. The center's participants will have access to gold standard specialist equipment, including DEXA scanners to measure bone density and body composition, metabolic, cardiovascular, and aerobic performance testing devices to measure a range of performance indicators, and advanced 3D motion capture systems integrated with force plates, a biomechanical measuring platform that can be used to analyze form, function, gait, and balance throughout movements. The center is located at the heart of Rice's athletics department, giving the university's athletes direct access to its comprehensive, science-based approach to personalized care and treatment, encompassing diagnostics, nutrition, innovative technologies for rehabilitation and recovery, and best practices for injury prevention. But the center's benefits will stretch far beyond sports science. Being so close to Houston Methodist will grant patients who want to be involved in clinical research studies easy access to enhanced approaches to recovery and rehabilitation, as well as shortening the time needed to complete the research and to make the new approaches available globally. All of this will make the center a research powerhouse, providing unrivaled opportunities for faculty looking to advance a career in fields related to improving human performance and creating a fertile environment for interdisciplinary collaborations. This pioneering research facility will be a game changer for scientists, students, athletes, and patients.
And what I'd tell you is that from our previous iteration of this lab, and even while this lab was under construction, we've been working in the lab, and we have over 40 medical publications just in the last few years doing this type of research. In fact, we won an award from Major League Baseball for the top research paper. We also won an award from the American Journal of Sports Medicine for the most downloaded podcast. And our future directions mean engaging other departments throughout the hospital and other institutions, Rice and the various departments at Rice, to look at not just research projects, but larger, more expanded lines of research. And you can imagine that some of our partners like the Houston Texans, who came through during their bye week, are interested in a lot of the work that we could help to pioneer for them. And from this, we hope then to attract attention from external funding like the Department of Defense, who's very interested in a lot of the things that we're doing. And right now, we're trying to recruit and retain new faculty, so we need another research engineer and more research coordinators to help us to care for our patients better, so that we can educate not just our patients, but people around the country and around the world through the work that we do. Thank you.
Thank you, Dr. McCullough. That is very, very interesting, and I have lots of questions. I've seen a few coming in across the lines as well. So I'm going to start with a couple concussion. We got a whole bunch of those on the front end, and now we're starting to get a whole bunch about yours as well, and a couple questions I've got. So one of the things that intrigues me, kind of as we think about the best thing around concussion, is going to be to not get them in the first place, right? And that's so much of what you talked about. You mentioned, I mean, those statistics are very compelling in terms of in competition versus practice. Right. There's got to be reasons for that. I mean, obviously some may just be how intensely you're going at things. I get that, but there's probably more to it than that. Walk me through why we're seeing that big a difference, and what can we learn from practice that can get applied to the competition setting?
One of the things that we've done is we increase that discrepancy by reducing concussions in practice, and one of the things that we've really focused on is reducing contact in practice. And there's now data showing that you don't need that contact to continue to develop that skill. In terms of competition, they are doing a lot of things in terms of having spotters on the field and trying to pull out players faster. So one of the reasons it is higher in competitions is we're paying more attention to it, and we're actually detecting the concussions that have always been there. We are working on ways. Rules is a very popular way of trying to reduce concussions, and you see that in football a lot. And I think we can expand that, extend that to other sports as well to reduce that in competition.
So some of it is simply avoiding situations that you can't really avoid in a game, right? If you're going to do non-contact, and
it's very hard
because you learn the skills in practice, you're going to have the contact in the full-fledged game. So that one probably doesn't have a carryover, but some of them may. When you think about something like the padded helmet you showed, I mean, is that something that you think something like that may find its way into pro sports, college sports, high school sports. You mentioned obviously the weight and the mass and the bobbing issue, so that I see a limitation also with how big is something you're putting on your head.
We will see this technology evolve, and it'll land up in the pros first because it's going to be more expensive initially. There's some exciting technology developing at University of Washington is coming up with shock absorbers that are fluid filled, and they can respond to the intensity of the hit and absorb some of that energy. And one of the interesting ways that they're trying to look at it is by figuring out how to deflect the energy when it gets hit. So that padding, the guardian cap, that's exactly what it does. It slides, so that just redirects the energy. So there is a lot of work that goes into that helmet technology. The problem is if you have two things in motion and they land up hitting each other, it's going to be very, very hard to completely eliminate that from happening.
Okay. Well, I guess a lot of hope that we can minimize some of those kinds of things in the future. Then, so okay, so a lot of the questions come from parents here. So you're a parent, you're on the sideline, you're watching this, and everybody's worried your kid might have just been concussed. Walk me through what that parent should be doing along with the coach and others, at that point in time.
Right. If there's an athletic trainer, they're professionals and they know how to spot the concussions, and they'll pull the kid out and evaluate them on the sideline and decide whether or not they need to be pulled out because of the concussion. Coaches go under training as well. So we do a lot of that to be able to spot it. If there's a concussion, they're going to be pulled, and we do monitor them every 20, 30 minutes for about the first hour and a half to look for those signs, to make sure that there's no danger signs developing. That's very rare. You're looking at about a 2 to 4% rate there. So they're going to monitor them, and then they're going to be handed off to the parent. The parent can take them home. If the symptoms are staying about the same, not increasing, no need to rush to the emergency room that night. And one of the things that we always try to emphasize is don't think that we need to scan their brains all the time. What we've seen is in the emergency room a 4-fold increase of CAT scans in our pediatric population with a 0% change in hospitalization. So all we're doing is adding a lot of this, and it's not necessarily needed. But again, if you have those danger signs, that's when we're going to ask you to take them to the emergency room.
So what specifically are the trainers going to be looking for to say, yes, we think you had a concussion versus, no, I don't think this is, was a concussion just something, less significant?
A lot of different symptoms or signs to look for. Something they call gait instability. If a player gets up and they wobble when they first stand up, right?
We've seen that, yeah.
Right. If they stand up and their head is still down, or if they're shaking their head a little bit. Any player that looks slow off of the start or off of the snap are things to kind of start looking for in the player. What we've done is, over the last several years, we've done a very good job in educating at a grassroots level, and now what we're seeing is students and athletes are reporting their concussions more if we don't necessarily see it, and so we've gotten a lot going with that. But anything that makes them look different, and what we need is sharpness. If there's any concern that they're concussed and they're not able to respond as quickly or not look up in the light a little bit, they're all indications that they probably had a concussion.
And if that happens, how long should somebody be out?
We usually, it's very individual, and it's definitely a few days, but what we do have is once they're asymptomatic, then they do have this return to sport protocol that we do follow. And what we do a lot that I didn't talk too much about is return to learn, getting them back to academics, which is a little bit more important than the sport.
Got it. Well, thank you. Well, I'm going to shift over to Dr. McCullough and Ed McCullough, and we'll come back because there's also a little bit of a intersection of these that was touched on, I think, in your presentation in the video a little bit. I'd love to hear like a great example of how you've used this, obviously maintaining privacy. So give me a general example of, how you've used this with Rice to really both in optimizing a player's performance and really bringing out the best in them, and probably in rehabilitating somebody who's been injured, and how you get them back at their highest level as quickly as possible.
For Rice and Rice Athletics specifically, having this center is really important for getting the most out of their athletes. So There's a similar center called the Nike Center at University of Oregon, and a lot of athletes who are out being recruited, they see that and they see the capabilities. And for Rice to have those capabilities and to have a partner hospital that's right across the street, that's actually a very big recruiting tool for them. We may not always get 4 deep in blue chip recruits in all of our sports, so we need to get the most out of them, and that involves injury prevention and as well as getting them back faster after injury. One example would be blood flow restriction training or blood flow restriction therapy, which is an idea that originated out of Japan over 10 years ago, where essentially we put a blood pressure cuff on a limb, and this could be a leg or an arm, and it has Doppler on it so it can measure how much blood flow there is. So we don't occlude all of the blood flow, but we occlude enough of it that limb is then a little bit starving for oxygen. Sort of like if you were trying to run the 800, right? The first lap might be okay, but that second lap, you're working really hard and all your muscles are on fire. Well, what we found in our studies, and we've published about a dozen papers on BFR out of the lab, is that when someone is injured or just had a surgery, they can't perform high-intensity exercise. We can't have them run or jump or squat 300 pounds. But what we can do is put this cuff on and then do low-intensity exercise. And the low-intensity exercise with BFR, it tricks the body into thinking that this is a high-intensity exercise. So we found that after ACL rehabilitation, for example, when they have ACL surgery, the group that did BFR as part of their physical therapy compared to standard treatment actually retained more bone mass and more muscle mass in that limb. And from that became standard of care for what we do in all of our physical therapy centers and on the Rice campus. We took it a step further to then say, well, what if we look at this as not just therapy for what we do in our rehab centers, but for training? Can we help them to build more strength? So, for example, baseball players, and Rice baseball is a historically good program. They always want to throw, every pitcher wants to throw harder, right? Mm-hmm. And they want to be a little bit more explosive or have greater spin rate. And there are lots of ways that people are going about doing this, like using weighted balls. And weighted balls actually can improve your velocity, but they're putting more stress on your shoulder and elbow, and therefore there's been a documented increased risk of injury with doing that type of training. So we took a different approach to say, hey, let's do our normal arm care exercises, but do them with blood flow restriction training and see if that makes a difference. And what we found is when we had 2 groups of pitchers, one who just did the regular arm care and one who did it with BFR, the BFR group had greater increases in lean muscle mass. And when we used our motion capture, we could say that it didn't change their mechanics in any negative way. And for that, we won a major award for Major League Baseball. And when we actually looked at then their fastball velocity and spin rate, it was slightly higher, which got a lot of people's attention.
But it did. Yeah, when you're talking very small margins in something like pro baseball, I think they make a huge difference, right? So they're trying to eke every last bit of performance out.
Yeah, it can. We actually have been in discussions with the New York office for Major League Baseball. They actually requested that we put in a grant. So this is not one that's going everywhere. They specifically wanted to work with us and the Human Performance Center, given some of the sports statisticians that are at Rice and our center, to answer some important questions for them, like looking at the fact that if we look at pitcher injury rates, they've been going up over the last 2 decades. So even though we're limiting the number of pitches and we have more pitchers in the rotation and all of the things that we're doing, we're still seeing Tommy John surgeries going up and shoulder problems going up. And so they want us to address that by looking at this from several different angles, and we're sort of well positioned to do that from an independent standpoint.
Okay, so I want to take it, that's one end of the spectrum. The other end of the spectrum is, not the elite athlete, but others that this can hopefully help. One of the questions that came in for us already, I was expecting this one as I was listening to you, was, hey, is this open to the general public? Can I get in? Talk a little bit about that.
Yeah, not exactly. So this is not it's not a patient care area, it's a research area, right? So it's open to our patients who are enrolled in studies that we're performing through our different departments. And so if you have an injury or a surgery performed here at Houston Methodist, you may be asked to join in a study, and this study may then take place across the street in the Human Performance Center. It is available to our partner organizations, so the Texans, the Astros, Rice Athletics, and the ballet, for example. So we do a lot of preseason testing and baseline testing for a lot of these performers in the center. And it is open to those within the society who might want to come and tour the facility and learn more about it. And we can schedule those visits.
Great. So I hear an open-ended, come take a look.
Sure.
If people would like
We'd
to
love
take
to
a look.
have you.
Yeah, and is there eventually, do you see some of this, getting put into, I mean, I know some pieces of it are, but some of it more being put into our physical therapy centers and others, and not just in injury recovery, but is there a whole field of the weekend warrior who wants to be a better runner, or who wants to be a better, whatever, softball player, whatever that is, of obviously insurance isn't going to cover that, but is there a opening for that for people? I mean, is that something we should be exploring?
Yeah, I think, the lab sort of sits in an interesting place where there are some things that are just medical, and those we do very well here at the hospital in our offices, right? And there are some things that happen on the court or on the field, and those are sports performance issues that often that's a strength coach and the position coach is doing that. And this sits right in between those two, right? So, for example, late stage rehab. So you might be well enough that you're sort of back to where you're no longer injured, but getting that next level of performance is important, and that's a lot of the studies that we're working on, and that goes for our hand surgeons and foot and ankle surgeons. We're looking at spine issues, so that's a big space. The other thing is in device design and development, which we're really happy to have those biomedical engineers on the Rice campus to help with this. Everybody's wearing these new wearable technologies, right. and if you wake up and you feel like you didn't get a great sleep, you look at your watch, which confirms you didn't get a great sleep, right? Mm-hmm. But how having that type of information, validating that, then allows us to look at interventions, right? And whether that's using our sports dietitians here within the Wellness Center, looking at sleep medicine. These are all really new frontiers to getting people to perform at a higher level, whether that's in your pickleball game on the weekend or it's Division I football.
Got it. Okay, well, then I mentioned the intersection. So you showed the balance testing device, and I think you commented one of the things you look for is even somebody who's staggering a little bit. How often do you use a device like that in your assessments?
It's very critical. Balance is a big part of getting those athletes back, and there's actually evidence that concussion increases the risk of lower extremity injuries more so than a prior lower extremity injury. It's the neuromuscular control. So there's a lot of interface looking at concussions and balance coming back from that. So there's a lot of synergy that does exist between the sports performance lab and the concussion center.
Well, one of the questions we got ahead of time, and there's another one coming in right now that's kind of, I'll extend this, is what are we worried about in terms of long-term concussions, right? We understand kind of why we're worried short-term and the double whammy you were talking about and other things, but what is it we're worried about over the longer term? And an associated question, when is it time to hang it up? Like when you actually sit there and say enough, there's been enough damage, enough concussions.
First question, long-term effects. There's a lot of unknown involved in that. So what we do know is that a history of remote concussion, let's say you got a concussion 10, 20, 30 years ago or more recently, immediately overwhelming majority of individuals will get better, right? Small percentage don't, and we do work on that population. But in terms of long term, the data is pretty consistent that you need that genetic risk factor for brain injury, right? So just like Alzheimer's has a strong genetic risk factor. And what the data shows is that 1 or 2 prior concussions may increase the risk of your dementia coming earlier if you were genetically predisposed to develop it. So for example, if genetics said you're going to show signs of dementia at 75, it might come out at 72. There's no evidence to say that it's going to affect you in your 20s, 30s, 40s, 50s, 60s. It's usually later on that we tend to see that. Okay. Second one, about when to hang it up. That's a very individual thing, and part of it is how severe was that head injury. That's number one. But after getting 2 or 3 concussions, we really start to look at, there may be 3 or 4 concussions is when we start to look at the individual. Are they recovering at the same rate that they've done historically? Are they becoming more symptomatic? Have the symptoms changed significantly? And then we tend to make that decision with the individual. And also depends on what are their goals, right? If their goal is to be a professional athlete, they might change a little bit. If it's a weekend warrior, then we're going to probably shut it down a little faster.
And then the last question associated with all of that, talk a little bit about CTE. Define it for everybody. How do we know when it exists, and what outside of some of what you've discussed could be done to prevent that or and treat that ultimately?
CTE stands for chronic traumatic encephalopathy. That's a neuropathological state. That's changes in the brain matter per se. Chronic traumatic encephalopathy has been associated with a clinical syndrome of memory changes, behavioral changes that occur earlier in life. Chronic traumatic encephalopathy is associated with what we call those subconcussive repetitive hits. It is not associated with concussions. So if you have 1 or 2 concussions, they need to be moderate or severe in order to produce CTE. Mild concussions are not going to produce it. If you play professional sport, boxing, where there's a lot of hits to the head, football, then there's that risk going forward. What the data shows so far, if you play through high school, there's really no risk of CTE greater than typical. College is a little bit more, and it is a little bit higher in the professional.
So it seems
football.
to be a cumulative.
It's a cumulative,
really smaller, recurrent kind of injuries in general.
Exactly.
What you're saying. Okay, interesting. Well, thank you. Well, I'm going to bring it. Well, actually, I have a quick question for you that came in. I want to make sure I get to that. Lacrosse do we see concussions in lacrosse?
Yes, I do. More in women's lacrosse than I do in men's lacrosse. Women's lacrosse needs to start mandating helmets. And to protect them a little bit more.
So we're seeing too many, right. And that's a lot of head-to-head
collisions,
or
stick,
sometimes the stick, because you've got the stick flying around. So okay, great. And then one last thing around human performance that came in ahead of time was thoughts around protein powders, vitamins, other things that might enhance performance. What do you recommend to your patients, and is that the kind of thing that might get studied in a setting like this?
It is, and that's a really good question. People ask this in my office every day, right? Comes with a couple of caveats, right? So one is that supplements are not regulated by the FDA. And so it's hard for physicians to recommend supplements not knowing what's in the supplement, right? And it could be that there's not any of the active ingredient in there. It could be that they've added something else, like testosterone in that, and so that's one problem. If someone wants to use a supplement, there are websites like the NSF, which is certified safe for sport. So if you ever hear about an athlete who says, well, I tested positive on a drug test because of a supplement that was, well, that's on the athlete, because they all know better, right? Mm-hmm. That they need to get their supplements from a particular certified supplier. The second thing is that for most people, dietary interventions are the most impactful thing that you could do, right? So a lot of people have a personal trainer because they're trying to work that side of the equation. But a lot of people have never even thought of seeing a sports dietitian, right? Which is a medical degree in nutrition, and we have them here. And so you need to optimize your nutrition. And for most people, that's sufficient. If we're talking about very high level performance, then yes, supplements could make a difference. And one of those is protein supplementation. So whenever you work out hard, if you lift weights, your muscles will get sore. And those muscles are actually breaking down some and then growing back stronger. Well, we can't have a lack of protein be our rate limiting step. So we need to make sure that we're having enough protein, and you can generally get that from good dietary intake. Adding a protein supplementation if you're doing a lot of intense workouts and they're back-to-back can be very helpful, and that whey protein is typically how that's done, and they have these pre-packaged products, Muscle Milk and others. One of the hot topics is looking at branched chain amino acids, which are actually just the little building blocks of proteins. And we have a study going on in the lab now looking at my patients after ACL surgery and giving them either protein or the branched chain amino acids to see which one is more effective. And then we use the DEXA to look at how well they retain muscle mass after the injury and after the surgery, and how quickly we can get them back to playing.
Fantastic. Well, that's fascinating. Well, hopefully everybody found all of that as interesting as I did. Thank you both, as always, for being here. You're both return visitors to this. I know we'll have both of you back again because you bring so much expertise. So again, thank you very much. I'm going to give a quick update on a few highlights of things going on at Houston Methodist. We started this series around COVID, so had to give you a little COVID update just because we do hear about it in the news these days. This is over the entire pandemic curve of hospitalizations at Houston Methodist. So if you look to the far right, you can see we are probably a little over the top of a peak, I think, although there's a little extra kick in there right now. And it's not a particularly troublesome peak from a hospitalization standpoint. Now, recognize it's still 150 people right now sitting, in a bed in one of our hospitals, so it's not insignificant at all. But in the scheme of where the pandemic has been at a lower level, we've been seeing wastewater levels continue to go up. They seem to be leveling off. It's become almost a clockwork kind of deal here if you look at the timing between these peaks, and if you look at the time of year we're in right now with the holidays and the colder weather and the winter. So I'm going to bet, based on previous years, based on what we're already seeing, that you're going to see much lower numbers come March into April. If you haven't gotten your vaccine, get your vaccine. It does help prevent severe illness, and for some matter of a few months, it will prevent infection as well. And so I always tell people, try and time these, as you see a peak coming up, if you're going to be getting an additional one. We've had a fair amount of very exciting changes around Houston Methodist of late. I mentioned how Debbie Sukin, congratulations to her, has become the new president of Texas Children's. We're very proud of her, but that sort of set off a cascade where I promoted Chris Siebenaller up to basically an executive vice president of network hospitals. So he has all the network hospitals, and with that we moved David Bernard from Baytown up to the Woodlands. Adrian Joseph actually got promoted at the Baytown up into the CEO role there. And then Michael Garcia, who was the COO at our main campus, has become the CEO out in Sugar Land. So very excited to be able to develop such wonderful leaders here and to see each of these individuals progressing. And I know they're going to do great things in their community. And I'll show you a picture later, but we're gearing up for the opening of Houston Methodist Cypress. And so we have now added a couple additional leaders there as we continue to flesh out the leadership team. So Dr. Nicholas Desai is now moving there as our Chief Operating Officer and Chief Medical and Quality Officer all at once. Those hats will split over time as the hospital progresses. He came from Sugar Land, and Nicholas Escobedo is going to be our Associate Chief Nursing Officer, who's come from Houston Methodist in the Medical Center as well. And so congratulations to each of them. And then now on board, I'd mentioned this before, our new head president and CEO of the Houston Methodist Hospital Foundation, Flynn Andrizzi, has joined us. So I hope many of you will get a chance to meet him soon if you haven't already, because he's already been attending many events and very active in now 2.5 weeks that he's been here at Houston Methodist. A couple big announcements. One is a wonderful year-end transformational gift from John from the Bookouts, honoring Mr. Bookout, who, believe it or not, is 101 years old now, and we've now named Mighty, which was part of his vision many years ago, along with Dr. Barbara Bass, as the Bookout Center for Medical Innovation, Technology, Research, and Education, as part of our Houston Methodist Academic Institute. So huge thanks to Ann and John for their generosity and for carrying on the legacy of their father and father-in-law. And we're just so excited to see what continues to happen there. Jim Francis, who some of you may know, but he's kind of a little behind-the-scenes operational guy, getting a lot of our IT handled, Vice President of IT Technology and Shared Services was actually on the cover of Health Tech magazine. Awesome picture of him, so congratulations to him. And Dr. Osama Gaber, who many of you know, won the Medal of Excellence Award from the American Association of Kidney Patients. So very much an impact award, even almost a lifetime impact award of how many kidney failure patients that he has touched with his illustrious career as a transplant surgeon and now as our chair of surgery at Houston Methodist. And speaking of transplant, last year was an absolute banner year. We had our 10,000th transplant ever, which is a very, very rarefied group of institutions that could claim that. And our record number ever of solid organ transplants, 663 transplants across our entire enterprise. And you can see kidney being number one, but liver, which is a very unusual, that is so close to the number of kidneys. And you can see we're in the top couple in the country in liver transplant, and really a very established and wonderful center for our institution. I always talk about focus on the awards, focus on the fundamentals. The awards will follow. We also focus a great deal on being a great employer, because we philosophically believe when we have the best people working here, we have the best outcomes for you as our patients. And these awards kind of tend to come in. Glassdoor, which many of you know is kind of a job hunting site and rating site, rated us number 37 across any kind of company anywhere in the United States as best places to work. There were only 3 hospitals on the list. We were the number 1 in the country, and so very pleased to see that kind of recognition. We're working with WebMD now around innovation video series, and you can see a list of those. If you Google that, you'll be able to find some really interesting around digital innovation and a lot of our work here at Houston Methodist. And then finally, to wrap up, we're blowing and going on the construction side. The long project, of course, is Centennial Tower, because it's 26 stories and because there's so much work underground. So this has been going on for about 2 years, and we are now getting well above ground, and every 2-3 weeks you'll see another story go up. So by the end of this year, this will top out. So very excited to see that. And starting construction at about the same time, but on almost a green field effectively, is our Cypress Hospital. This is getting close. Actually, those 2 office buildings will be complete and starting to be turned over to us, then move-in tenants by the beginning of March and the beginning of April, respectively, meaning by April into May, we will actually be running clinical enterprise there. The hospital will be turned over to us in November, so meaning by this time next year, we're going to be running this hospital, which is pretty exciting that we'll be able to serve that region in Houston as well. So I thank you each for being here as always. Look forward to next month. Our next one will be on a Thursday again, February 15th, so we'll look forward to joining you at that time. I want to thank our 2 presenters. I want to thank a couple of individuals we had who were in the background answering your texts and questions, and I want to thank each of you for your support and your attendance. Have a great day.